now we're going to go over some of the neurological and psychiatric conditions as associated with your geriatric. So first up, neuro. So of course the biggie, the strokes, right? Stroke is the leading cause of long-term disability and death in older people. It's mainly caused by atherosclerosis, and the risk factor doubles every decade after the age of 55. And of course, these risk factors in general: hypertension, age, history, smoking, diabetes, high cholesterol, heart disease, and then normal stuff too, like vascular elasticity loss, slowing conduction system, that kind of stuff. So really, the older you get, the higher the risk of a stroke. So, of course, reducing the risk factors is awesome. Improving diet, increasing exercise, lowering cholesterol, that kind of stuff. Our pre-hospital care, early recognition is the number one thing we need to do. Recognize when they have a stroke. Finding out, is there any kind of condition that can mimic a stroke? Timely transport to an appropriate facility to get them those fibrinolytics if they qualify, or whatever they need. Using the appropriate stroke assessment tool, whether it's the FAST, the Los Angeles, the Cincinnati, whatever appropriate stroke assessment tool is used wherever you work. But, keep in mind some history too. Older person with arthritis, for example, may not move as well on one side. Maybe they've had a history before. So we want to make sure that we're asking these family members and these caregivers, getting information about their baseline cognitive status, their physical status. Is that drooping left side new? If it's not, where did it come from? Is it a previous stroke? Is it, just differentiating between old and new symptoms, that kind of stuff. Personality changes are kind of happen with this sometimes too, because especially if it's, say, in the frontal lobe or something like that, they may have an acute change in the personality. Don't assume that grandpa's being a butthead just because grandpa's being a butthead. Maybe grandpa normally is like Santa Claus and he's the nicest person in the world, and he's had a stroke, which is making him not so nice anymore. Right, and then we want to look at activities of daily living as well. Is this interfering, or has it started interfering? They're not able to do things that they used to could do, or what can they normally do? Can they normally bathe themselves, take care of themselves, and now all of a sudden they can't feed themselves? So we want to find out what their basic functioning level is. We also want to look at the cognitive function, like recalling events and following commands and that kind of stuff. And family members and caregivers are going to be our best placed oftentimes to get this kind of information. As far as dealing with the TIA, or transient ischemic attack, we can't tell in the field if this is a stroke or if this is a TIA. All right. By definition, it's stroke-like symptoms that resolve on their own in 24 hours. We don't know. Okay, so the big thing here is if they've had a history of TIAs, the more TIAs they've had, the more likely they are to have the big one, to have an actual stroke at some point. So we assume that all of them are going to be a stroke instead of a TIA, and treat it as appropriately as a stroke. Okay, moving on to delirium. So delirium is not a disease in and of itself, but it's often a symptom of all kinds of other stuff. Technically, it's an acute brain syndrome or acute confusional state. It is usually temporary, okay, and it's just a reflection of some kind of underlying problem, and it's usually reversible. Right? So with an actual delirium, there's a lot of characteristics: disorganized thoughts, inattention to detail, disorientation, big changes in personality and their effect, how they present themselves, hallucinations, confusion, bizarre behavior. They may go back and forth rapidly between mental states like lethargy and agitation, disorganized thoughts, changes in perception and sensations, that kind of stuff. These symptoms really can mimic an intoxicated state, or drug abuse, or even some severe psychological disorders like a schizophrenia or something like that. So when we are assessing for them, we really want to kind of look for an acute onset of anxiety, or maybe an inability to think logically or maintain the intention or focus. Those are often some of the earlier signs that we'll see early in a delirium. We want to make sure we're looking for changes in the vital signs, the temperature, glucose, medications. Those are some of your more common causes of your delirium. With your geriatric patients, a lot of times, we've mentioned a couple other things, but a lot of times delirium kind of replaces the typical presentation caused by a medical problem, or maybe an adverse medication effect or drug or alcohol withdrawal, things like that. Your causes of deliriums, you got your deliriums is what you remember it, but your D is drugs or toxins. E is emotional, which would be like your psychiatric. L is your low PaO2, carbon monoxide, CO2, or COPD, CHF, heart failure, pneumonia, that kind of stuff. Anything that's going to cause low oxygenation. I for infections, that one's a very common one, especially UTIs and sepsis. Ooh, buddy. R for retention of stool or urine. I for ictal, seizures. All right. U, undernourishment or underhydration. M, metabolism, or S for subdural hematomas. So all these things are kind of some of the more common causes that can cause delirium. Most of the time, if you can kind of figure out what the underlying problem is and resolve it, then usually it'll reverse itself. Right? Now, keep in mind, this delirium onset is going to be very quickly. It's not going to be over days to months to years. We're talking hours to days at most. Alright, but like I said, usually it's going to resolve with the treatment. So we're mainly trying to figure out what the underlying problem is. It could be a little more complicated getting the medical history, so you may have to rely some on the caregivers or family members as well. So sometimes confused with delirium is dementia, but dementia is its own thing, okay? And this is irreversible brain failure. These signs and symptoms come on over months to years, and here we're looking at memory loss, attention span issues, aphasia, hallucinations, confusions, disorientation, inability to retain new information. A lot of times you'll see personality changes. They kind of have social withdrawals or inappropriate behaviors, that kind of stuff. With your dementia, it's usually caused by some kind of condition that's going to impair the vascular or the neurological brain structures, infections, strokes, head injuries, poor nutrition, medications, that kind of stuff. Now, there are two more common degenerative dementias, and one of those is probably familiar with, Alzheimer's, and the other one is called a multi-infarct or vascular dementia. And with the vascular dementia is caused by changes in the brain, usually due to several TIAs, strokes, or something like that, or circulation in and of itself. It can also be caused by like brain tumors, emotional disorders, Parkinson's, Huntington's. There's a lot of stuff that can really cause different degrees of dementia. Now, as far as diagnosis of dementia, this is going to be when you have two or more cognitive or psychomotor brain functions that are impaired: language, memory, perception, emotional behavior, personality, or cognitive skills. Once again, we're not diagnosing this in the field. This is going to be something that's been going on. Most of the time, because dementia is more of a chronic problem, when we get called in, a request for emergency care is going to be related to either a new presentation of dementia-related symptoms or an inability to kind of manage the behavioral disruptions or something like that. There was no specific treatment, but we need to remember that acute changes could be from a result of something new. This is a progressive thing, but there can be acute changes as well. So what we're going to do is get our baseline from the caregivers, find out what their normal behavior, their normal abilities are, and find out specifically what happened to lead for us to get called out here today. Is it a behavioral issue? Is there something new going on? All right, check the information. Make sure that we're getting is everything we need. Be careful with patients, okay? They may be weaker, but they may still attempt to harm you because of confusion or anxiety, okay? There's a higher risk for caregiver abuse because the patients may not be able to accurately report injuries or neglect, and it can be frustrating dealing with a patient who has one of these dementia diseases. So, we may want to make sure that we are familiar with home health agencies, respite care, and other services that may be helpful for the patient and their patient's caregivers. Now, Alzheimer's in and of itself is the most common form of dementia, and it's a progressive function loss. It starts early on. There's different levels. There's several different levels, but it starts early with just subtle signs, losing things, not being able to think clearly, losing track, that kind of stuff, and it'll progress to full-blown losing identities and forgetting your own experiences, all the way to the end stage where you lose the first couple of years of life. You forget how to walk, how to feed yourself, how to exist, really. Early signs may be like confusion, changes in personality, or difficulty with daily activities of living. Like I said, early stages, you've got mild cognitive impairment. This is the forgetfulness, things like that. Diminished problem solving. The early stages, you start having language problems, misplacing items, getting lost, personality changes. I remember my grandmother had Alzheimer's, and early stages that lasted for years, we kind of chalked up to her quirkiness because she was always a little quirky. And it was just later on, once we had a full diagnosis, that it was like, oh, looking back, it became obvious, like misplacing Christmas items and things like that. I remember one time she went to the doctor's appointment in Montgomery, somewhere she'd been many, many, many times, and she called us and she had gotten lost. She'd gotten turned around somehow, ended up in Fort Deposit, a solid hour or so away down the interstate, and my mother and I had to go get her. So it really is a progression to where, and it's frightening for the patient as well. Like, it's frightening for the family. I can only imagine how frightening it is for the patient when they realize that they aren't remembering things but don't know what to do about it. And then the progressed stage is, forgetting current events, this changing in sleep patterns, difficulty with reading and writing. I remember B, as my grandmother, she would stay up for hours and hours, and Lord, she loved the heat. It'd be August, and she would turn on the heater and have it like 75, 80 degrees in that house. Towards the end stage, they have a harder time understanding the language. They may not recognize close family members. They can't perform self-care. At her end stage, we were very fortunate that she had a assisted living near our house, and so we went and fed her, all 3 meals a day. Somebody was there at every meal. We helped her get dressed. We helped do everything. She forgot who my brother was, my uncle, my dad, me. She kind of either didn't know who we were, or sometimes like she would think that my younger brother was my dad when he was little. She had regressed a good bit, and good days and bad days, it just changes from day to day. So with Alzheimer's, it's not a specific test that they can do, but basically they rule out, it's an exclusionary disease where they rule out other causes of dementia. The only true way to diagnose it is through an autopsy after death. They have these little neuro tangle things that the neurofilaments that kind of wrap around and block off the nerve cell nuclei. All right, and it develops this kind of plaque when these dead neurons accumulate. So if they see that, then they know, hey, this was Alzheimer's for sure. But that doesn't work when they're still alive, obviously. So our treatment here, pre-hospital treatment, communicate slowly, be patient, evaluate for anything else that could be causing these new onset of signs or symptoms. One of my favorite calls, I always get tickled about it, is when you go to a dementia patient who's altered, because it's like, well, they're always altered, right? But it's important to find out why they're altered this time. What's different from the normal baseline? Like I said, check for other illnesses. Consider maybe some antipsychotics if they are combative or dangerous. And it's not so much that they're trying to be combative or dangerous, it's that anxiety. They don't know what's going on. They may not be aware of what's happening. So a little bit of grace will go a long ways as well. Maybe we'll consider some benzos for sedation if needed, if the verbal communication doesn't work. As far as their medications, they may take antidepressants, they may take other medications that are supposed to kind of slow the decline of your Alzheimer's disease. But they really don't know what specifically causes it right now. Parkinson's. So Parkinson's is covered pretty well in the medical stuff, but it is an age-related neurological disorder. 2 or more symptoms: resting tremor extremities. That didn't make sense. Resting tremor of an extremity, slowness of movement, kind of a rigidity or stiffness in their movement, and poor balance. Okay, it can affect one or both sides of the body, and it can produce a wide range of functional loss. Could have some dementia, depression, autonomic dysfunction, the self-regulatory stuff can go wrong, instability in their posture, that kind of stuff. So there's a lot of different ways that it will kind of present. For us, pre-hospital treatment, supportive care, transport to appropriate facility. All right, seizures. So seizures incidents go up a little bit in elderly because of more risk factors, more risk, secondary strokes, dementia, brain tumors, acute metabolic disorders, that kind of stuff. Treatment exact same as anybody else. Now, moving on to the psychological conditions. All right, depression, not a normal part of aging. It is considered to be a medical disease. It could be a normal short-term reaction to some event, or it could be an abnormal progression of disease. The real concern is when it persists for weeks and weeks and weeks. And there is evidence that's showing where depression is becoming a major health problem for the geriatric population. And, kind of like, well, why is that, But think about it. You've got more diseases, more problems wrong with you. You've got the psychosocial stress. You maybe can't get around as well as you used to. Maybe you can't see your friends as well. Maybe you're dependent on healthcare services or something like that. You've got age-related brain changes that lead to cognitive impairment. So, all these things kind of increase the odds of having depression. And when you take more medications, then you have the possibility of more toxic effects. And something to keep in mind too is that depression can mimic the effects of a lot of other medical problems. So don't just write it off as, oh well, they're just sad. All right, your risk factors, of course, having a history of depression, having some kind of chronic disease, losing that function, that independence, being, losing significant others. I can only imagine if your husband or wife or of, 30, 40 years, whatever, you lose them, what do? You don't know life without them anymore. So a lot of different changes that can happen that can cause depression. With this, sometimes older people, especially men, not saying anything, just saying, tend not to complain or talk about their feelings. So it may be kind of difficult to recognize if they have these issues with depression. The majority of your geriatric suicides, which blows my mind, like, why, you don't want to think about that, but it happen in people who have terminal illness or debilitating cardiac or neurological conditions. Right? The suicide rate's actually a little bit higher than you would think it would be. So when we're looking at, usually when we get involved, is if there's some kind of behavioral emergency, some kind of psychologic emergency, okay? So we want to find out, is this a behavioral emergency or behavioral crisis, all right? If it is, behavioral crisis is an overwhelmed patient who can't cope, okay? But behavioral emergency is when there's a significant risk of serious harm to themselves or to others, okay? They may be in a suicidal state. They may be in a potentially violent state. They may have impaired judgment. So that's when we really need to step in.